Hello students, this is Dr. Frances Munroe from the George Washington University School of Nursing. I'm here today to talk with you about heart failure. This is part one of a two-part lecture series on heart failure, and today we're going to talk about the initial presentation and the diagnostic workup of a patient with suspected heart failure. Next, let's take a look at the epidemiology, the incidence, and the prevalence of heart failure. It is known as primarily a condition of the elderly, and right now more than 650,000 new cases of heart failure are diagnosed annually in the United States. Not only is the prevalence high, but the mortality rate remains very high, with over 300,000 people dying every year from heart failure. The incidence approaches about 10 per 1,000 population after the age of 65, with totals reaching about 6 million adults in the U.S. right now. 80% of those who are hospitalized are greater than 65 years old with heart failure, and there are over 1 million admissions each year. It is the most common Medicare diagnosis-related group, with more money spent for the diagnosis and treatment of heart failure than for any other diagnosis. Costs have reached greater than $39 billion, and that was estimated in the year 2010. Therefore, it's very important that we have appropriate diagnosis and therapy for heart failure, especially given the poor prognosis. Very important for family doctors, family nurse practitioners, primary care providers to understand both the pathophysiology of heart failure and apply the known effective treatment for it. Heart failure has an estimated overall prevalence of about 2.5%. Unfortunately, it's becoming much more common in older adults because of increased survival after acute MI and improved treatment of coronary artery disease, valvular heart disease, and hypertension. As I mentioned earlier, the mortality rate from heart failure is very high. Survival is about 90% at 1 month from diagnosis, but drops to 78% at 1 year and only a little over 57% at 5 years. So patients with heart failure have 3 times greater the chance of dying within 3 years than patients diagnosed with breast cancer. More than 300,000 U.S. deaths per year are attributed to heart failure, and this may be underreported because it has not been a recordable cause of death listed on death certificates. Heart failure is defined by the American Heart Association and the American College of Cardiology as a complex clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the ventricles to either fill with blood or eject blood. As cardiac output decreases because of stresses placed on the heart, there is an activation of the sympathetic nervous system, the renin-angiotensin-aldosterone system, which increases blood pressure and blood volume, again enhancing preload, stroke volume, and cardiac output according to the Frank-Starling mechanism. But these compensatory mechanisms can also lead to further heart damage, deterioration, and worsening contractility. So overall, heart failure is a clinical syndrome that results from the inability of the heart to meet the metabolic requirements of the body. Although heart failure can be caused by left ventricular systolic dysfunction, it can also be secondary to diastolic dysfunction. Heart failure with preserved ejection fraction is nearly equally common to heart failure with a reduced ejection fraction. Fluid retention, pulmonary congestion, edema are hallmarks of heart failure, but they are not always present. And in fact, many patients can describe dyspnea and a loss or reduction in exercise capacity and have no fluid overload. So because pulmonary congestion may be absent in heart failure patients, the term heart failure is now preferred over congestive heart failure. So if we look at the clinical presentation or the symptoms that patients may complain about, the hallmark is usually shortness of breath, decreased exercise tolerance, and it is a challenge determining whether it is heart failure versus just fatigue, or is there a physiological abnormality due to aging, deconditioning, other medical disorders such as pulmonary diseases. Fluid retention is typical, again, usually in the lower extremities. There may be abdominal swelling, and there may be no symptoms or symptoms that are cardiac in nature, abnormal heart sounds, abnormal EKG, chest x-ray, hypertension, usually the presence of arrhythmias, a thromboembolic event, previous MI. We see the remodeling of the left ventricle, and that indicates a reduction in left ventricular function. This remodeling process can be triggered by many potential injuries, as we've noted before, and it can be a reversible process with appropriate therapies. Coronary artery disease is the underlying etiology in up to 70% of patients with systolic heart failure. It is a very strong predictor for progression from asymptomatic to symptomatic left ventricular systolic dysfunction. Hypertension, valvular heart disease are also significant risk factors for heart failure, and diabetes increases the risk of heart failure twofold because it directly leads to cardiomyopathy. It is a very significant contributor to coronary artery disease. It is actually one of the strongest risk factors for heart failure in women with heart disease. Smoking, physical inactivity, obesity, and a lower socioeconomic status are also significant risk factors for the development of heart failure. Some other factors and other comorbidities and conditions that can worsen heart failure include renal insufficiency, renal failure, cardiotoxic medications, and then lifestyle habits such as smoking, drinking, or illicit drug use. An important point to remember is that heart failure is a progressive disorder. Although it can start with some left ventricular dysfunction, it can also be secondary to diastolic dysfunction. It starts with the hypertrophy and then the cardiac remodeling that can occur over months to years. The development or worsening of either heart disease, diabetes, hypertension, or the onset of atrial fibrillation will also worsen heart failure. Most patients with heart failure have greater than 5 comorbid conditions, usually including heart disease, diabetes, hypertension, and they take greater than 5 medications on a daily basis. In 2014, the American College of Cardiology and the American Heart Association updated their guidelines for the management of heart failure. Several years before, they described 4 stages for the new classification of heart failure, and this was designed to emphasize the progression to heart failure over a continuum and also the preventability of reducing risks of heart failure in patients with comorbid conditions. This classification system complements the New York Heart Association classification, which we'll talk about next. So if we look at stage A, this describes patients who are at risk for heart failure but are completely asymptomatic. They have no structural heart disease. More than 60 million people fall into this category in the United States and includes those with hypertension, diabetes, and a family history of cardiomyopathy. Stage A is an additional classification, and it was not present in the prior New York Heart Association class. Stage B are patients with left ventricular dysfunction, but they are asymptomatic, no complaints of dyspnea or exercise intolerance. This includes about 10 million people in the U.S. right now. Stage C describes patients with left ventricular dysfunction who are symptomatic with fatigue and dyspnea on exertion. They do have structural heart disease, and This includes about 5 million people in the U.S. right now. Lastly, stage D patients. This describes patients with refractory heart failure who require specialized interventions. They have symptoms at rest and includes about 200,000 people in the U.S. This classification system helps you to follow patients as the heart failure progresses. The New York Heart Association classification system is a little bit older, but it is very simple, and it is the most widely used method to monitor symptom severity. It is a well-established predictor of mortality, and it can be used at the time of diagnosis and in follow-up to monitor treatment response. If we look at Class 1, that is the asymptomatic patient who has no limitations. Class 2 heart failure are patients who are symptomatic with just ordinary exertion. They have slight activity limitations. And Class 3 patients are symptomatic with less than ordinary exertion. They have marked limitations. And the very last class would be Class 4. These are patients who are symptomatic at rest. They are unable to engage in any physical activity at all. Again, these classes are used to help to assess the symptoms and determine the appropriate treatment for heart failure. So the initial evaluation of our patient with suspected heart failure would include a complete history and physical examination. Some of the signs and symptoms of heart failure include dyspnea, orthopnea, paroxysmal nocturnal dyspnea, cough, either exertional or when lying down. They may notice some easy fatigue, generalized weakness, palpitations, chest pain. You would want to question them about weight gain, any swelling in the feet or ankles or even in the stomach area. A patient may even complain about some abdominal bloating, epigastric discomfort, or ascites. Certainly you want to ask about the past medical history, either prior episodes of heart failure, history of coronary artery disease, diabetes, hypertension, arrhythmias, or valvular heart disease, and inquire about a family history of heart disease, cardiomyopathies, or heart failure. Careful listing of all medications, including both prescription and over-the-counter medications, and then a careful social history looking at risk factors such as smoking and drinking, illicit drug use, diet, exercise, and stress levels. Also important to note their intake of salt and daily fluid intake. A comprehensive physical examination should be done from head to toe with particular attention to the cardiovascular system. You would want to note the patient's appearance on arrival. Are they short of breath? Do they exhibit signs of cyanosis, diaphoresis, or pallor? Complete vital signs including height, weight, BMI, pulse oximetry, temperature, pulse, respirations. Careful auscultation of the lungs, listening for rhonchi, wheezes, rales, measuring AP diameter. Cardiovascular exam would be very important to look for the presence of a third heart sound, a ventricular filling gallop. It is an early indicator of increased left ventricular and diastolic pressure and decreased left ventricular ejection fraction. Even though it is an uncommon finding, the third heart sound and a displaced cardiac apex are very good predictors of left ventricular dysfunction, and they can rule in the diagnosis of systolic heart failure. If you add the presence of jugular venous distension or JVD along with hepatojugular reflex, rales, and peripheral edema, this is indicative of volume overload, and it certainly increases the probability of a heart failure diagnosis. The absence of any of these findings is of little help in ruling out heart failure, but the presence of these findings can help to rule in heart failure. This slide shows us a nice reminder of the auscultation of heart sounds, showing us the position of all the heart valves and the importance of listening for any murmurs or any other abnormalities. And this slide is a nice reminder that patients should also be examined in the left lateral position for the auscultation of heart sounds, particularly useful when you're looking for murmurs, especially of the mitral valve or the tricuspid valve. Because heart failure is pretty much a clinical diagnosis based on your history and physical exam findings, there is no one single diagnostic test that is the gold standard. The initial laboratory evaluation, however, should include a complete blood count, urinalysis, fasting lipid profile, liver function testing, measurement of electrolytes including calcium, magnesium, BUN, creatinine, fasting glucose, thyroid stimulating hormone, A1C, and when needed, you may want to do serial monitoring of renal function testing and measurement of electrolytes dependent on treatment. The BNP, also known as B-type natriuretic peptide, is a very important test in helping us to identify the progression of heart failure, and it is very useful in evaluating patients with dyspnea who you suspect have heart failure. BNP is secreted by the atria and the ventricles in response to the increased wall tension of the heart. However, BNP levels normally increase with age. They are higher in women and African Americans, and they can also be elevated in patients with renal failure. So you want to keep that in mind. But BNP appears to have better reliability, especially in older populations in diagnosing heart failure. And multiple research reviews have shown that BNP can effectively rule out a diagnosis of heart failure. It has a very good negative predictive value, meaning if it is normal, then you can rule out the heart failure. As BNP levels increase, the specificity of the test increases, and thus the likelihood of a heart failure diagnosis is more solid. So BNP levels are very strong predictors of heart failure mortality at 2 to 3 months and cardiovascular events in acute heart failure, especially when the BNP level is markedly elevated, let's say more than 200 pegs per ml. Also, we would want to look at other diagnostic tests such as chest x-ray and PA and lateral, which will help you to rule out other causes for heart failure, such as lung disease and any other pneumonias, pneumothorax, lung masses. Pulmonary venous congestion, interstitial edema can be noted on chest films, especially in a patient with dyspnea, and that will also help to make the diagnosis of heart failure more likely. 12-lead EKG is very useful in identifying other causes of heart failure in patients and also to rule out other problems. You may see changes such as a left bundle branch block, left ventricular hypertrophy, acute or previous MI, atrial fibrillation. Again, you may notice abnormalities that you want to further investigate using either stress testing or cardiac catheterizations. 2D echocardiogram with Doppler flow studies is the most widely used and available method for identifying systolic dysfunction, and it should be performed on initial evaluation to confirm the presence of heart failure. 2D echocardiograms can assess left ventricular ejection fraction, left ventricular size, wall thickness, valve function, and the pericardium. It is very helpful in diagnosing diastolic heart failure if elevated left atrial pressures or impaired left ventricular relaxation is present. So the diagnosis of diastolic heart failure is clinical without conclusive echocardiogram evidence. So if echocardiograms are abnormal and there is angina or chest pain, then you may want referral to cardiology at that point for the patient to undergo a cardiac catheterization. If we take a look at a chest film, we can certainly see the presence of cardiomegaly. You may also see the increased vascular markings in the upper lung zones. You can note that the right heart border is a little fuzzy. There is some increased markings even on the right side of the heart, fluid in some of the tissue. You can also see that on the left side. Portions of the left heart border are also indistinct, and the upper lung fields have a little bit of a hazy appearance, indicating some mild edema, and you can see some fluid present. On the lateral view of the chest x-ray, you can see the curly B lines, again increased markings showing the fluid present in the lungs. So preload refers to the end diastolic volume. It is the amount of blood that is present in the ventricles just before contraction. If we look at a review of the Frank-Starling law, it is the relationship between the diastolic volume and the force of the myocardial contraction. So increased volume lengthens the fibers and increases the muscle tension, which equals a greater force of contraction equals a larger stroke volume. Afterload refers to the impedance that has to be overcome in order to eject blood from the left ventricle. And this is primarily determined by the aortic blood pressure, and a high blood pressure will increase the left ventricular afterload. So vasodilating agents that reduce blood pressure can also significantly reduce afterload. An increase in afterload, however, results in a decrease of stroke volume unless you adjust the contractility, the preload, or both. Contractility depends on several factors. It is determined by the amount of contractile proteins in the muscle cells, the availability of ATP, the free calcium ions, positive inotropes such as epinephrine, thyroid hormone, caffeine, or digitalis, and the presence of negative inotropes such as calcium channel blockers, the parasympathomimetics, or the sympathetic blocking drugs. Ejection fraction indicates the pumping efficiency of the ventricle, and it is calculated by stroke volume divided by end diastolic volume. Normal ejection fraction is usually between 60 and 80%, and it is obviously influenced by all three factors: preload, afterload, and contractility. A reduced ejection fraction is very common after myocardial infarction, and many times you'll see it below 25%, which indicates heart failure. This is determined by the 2D echocardiogram. It's important for providers to determine whether ventricular dysfunction is systolic or diastolic because treatment strategies are very different. Some of the therapies for systolic dysfunction can be harmful if they're used to treat preserved systolic function. In patients with heart failure symptoms, it's important to determine whether they have left or right ventricular systolic dysfunction or preserved systolic function. 1/3 of patients usually have preserved systolic function, 1/3 have both systolic and diastolic dysfunction, and 1/3 have predominantly systolic dysfunction. So systolic dysfunction is the inability to contract the ventricle. It is the most common cause of heart failure, and it is now called heart failure with reduced ejection fraction. Usually the left ventricular ejection fraction is less than 45%, that's by definition, and severe systolic dysfunction, you would have an LVEF of less than 25 to 30%. Diastolic heart failure is the inability to relax the ventricle, and it's usually characterized by the decreased ability to fill and lower rate and volume during diastole and high-end diastolic pressures. It is now called heart failure with preserved ejection fraction. This is a pretty nice table that shows a good comparison between systolic versus diastolic heart failure. Again, looking at systolic dysfunction as more of a pump problem and diastolic dysfunction as more of a filling problem. If we look at the ejection fraction, usually abnormally low in systolic dysfunction, a normal ejection or preserved ejection fraction in diastolic dysfunction. Heart size is enlarged with systolic dysfunction. Again, the underlying problem is a decrease in left ventricular contractility caused by heart disease, MI, congestive cardiomyopathy, or valvular disease. Diastolic dysfunction usually have the normal heart size, normal contractility, but an increase in the stiffness of the left ventricle and decreased compliance, impaired relaxation caused by hypertension, left ventricular hypertrophy, pulmonary edema, pericarditis. This is a nice picture showing some of the clinical manifestations of what we call left-sided heart failure. And again, this shows the backward effects, shortness of breath on exertion, orthopnea, cough, paroxysmal nocturnal dyspnea, cyanosis, rales, crackles, and the forward effects with fatigue, tachycardia, confusion, anxiety that are very typical. And this picture shows us what the clinical manifestations of right-sided heart failure look like. Again, the backward effects of hepatomegaly, ascites, JVD, peripheral edema, and the forward effects very similar: increased fatigue, tachycardia, restlessness, confusion, and anxiety. This slide shows a nice review of heart failure and the dysrhythmias. It talks about the baroreceptor response in the brain that activates the sympathetic nervous system, resulting in increased heart rate, increased contractility, and increased cardiac output. We also see the activation of the renin-angiotensin-aldosterone system, also known as RAS, and that activates the kidney, causes some fluid retention, which increases preload, increases cardiac output. And then as there's disease progression, we will see an increase in ventricular wall tension, a remodeling that's going on in the heart, leading to hypertrophy and increased cardiac output, all in an attempt to compensate for the dysfunction of the heart. So in summary, when we look at the progression of heart failure, we're looking at the sympathetic nervous system being activated, enhancing the preload and cardiac hypertrophy, which allows the heart to compensate for the systolic dysfunction. And this can go on for an extended period of time. It's a very effective way to increase cardiac output during an acute process. However, when that sympathetic nervous system activation becomes a very chronic process, it is very harmful to the heart overall. The decompensation eventually occurs when the primary disease plus the superimposed burdens of compensation eventually overwhelm the heart. I'd like to thank you for your attention today. Part 2 of this series on heart failure will focus on the management and treatment of heart failure.